Good morning, ladies and gentlemen. Uh, Topic for today was stents versus bypass surgery. I think that we can go in for a discussion regarding whether to put in a stents or send the patients for a bypass surgery. This has been a debate for many months, many years. There are certain standard indications for putting in stents, some standard indications for bypass surgery, but there is a big overlap between these two modalities. If we see a coronary angiogram, of course, we need to study our coronary angiograms in relation to their anatomical and morphological features. We should see whether the patients have proximal lesions, which basically means that they supply more myocardium, and hence the function significance of the proximal lesions would be much more than the distal ones. Whether the lesion is calcified lesion, because we know that hard calcified lesions behave differently as they do not open adequately and have greater chances of subacute thrombosis and restenosis after the stents. We should also know that diffuse lesions, the lesions which are very long, of course behave badly with stents because they require long stents, they require overlapping stents, and hence increased recurrence rate. For making a point that whether this patient would require a CABG or whether this patient would require a stent, we should also know certain things, that initially all non-drug eluting stents and drug eluting stents, the restenosis rates are different. There are certain situations where the vessel size is more than 3.5 millimeter. Of course, the recurrence rate in the non-DES and the drug eluting stents would almost be similar. But the odd persons, patients who are having an overlapping stents, patients with vessel size less than 3 millimeter, diabetic patients, patients with chronic total occlusions, with bifurcation lesions, the lesions which are longer than 15 millimeter, the longer lesions, diffuse lesions, and osteal lesions. Once we were using the non-drug eluting stents, you would agree that the restenosis rates were almost in the range of 20 to 25% or even 30%. However, with the advent of drug eluting stents, the recurrence rate has come within less than 10% to the tune of 6 to 8% or 5 to 7%. We always study our coronary angiograms in context with whether the patient is having a single vessel disease, a double vessel disease, triple vessel disease. The patients with triple vessel disease with focal 3 lesions, or a multivessel disease with multiple lesions, left main disease, isolated or with various combinations, the patients who have presented to us in acute myocardial infarction, and we should always study these subsets with one variable, that whether the patient is having associated LV dysfunction or the patient are having a normal LV functions. Let's discuss out a single vessel disease patient. By choice, all single vessel disease patients or a single lesion vessels, the angioplasty with stent would be the procedure of choice nowadays, especially with drug eluting stents with a reasonable recurrence rate. But where a patient is having an osteal lesions in the small vessels, we discussed it out. The patients who are having a diffuse disease, bifurcation lesions, or hard calcified lesions, or patients with severe LV dysfunctions, even with single vessel disease, the choice may tilt in favor of a bypass surgery. Here is one such patient. Of course, you see a tight proximal lesion in the left descending artery. The right coronary is of course normal. Put in a stent and beautiful result after the angioplasty. For a double vessel disease, again the double vessel disease with two focal lesions, the standard choice would be an angioplasty with stent. However, again, if the double vessel disease with multiple lesions are there, which require multiple stents, complex bifurcation lesions, osteal lesions, diffuse calcified lesions, that this may tilt the favor in favor of bypass rather than stents. Again, the variable would be LV dysfunction or the patient having a normal LV functions. If the patients are having LV dysfunction, even with a double vessel disease, it tilts in favor of a bypass rather than stents. For a triple vessel disease with focal lesions in all three vessels, the results as of today are comparable with multiple drug-eluting stents versus bypass surgery. However, the standard procedure of choice as of today with triple vessel disease diffuse lesions would be a bypass. Here is one gentleman in whom we put in stents. He had a 3-vessel disease. He was given a stent in the RCA, mid-RCA. He was given a stent in the proximal LED, and he was given a stent in the circumflex. These stents were put 5 years back, and this is a follow-up angiogram done just 1 month back, saying that obviously all 3 stents are patent and the patient is still doing fine. The focal 3 lesions in a triple vessel disease, yes, the patient may undergo a stents rather than going in for a bypass. What about left main disease? So, left main with associated double vessel or triple vessel disease, of course, bypass is a standard choice. However, let's discuss out certain issues of isolated left main disease. The latest data from the various clinical trials comparing PCI with bypass in left main disease is encouraging. So, as of today, the isolated osteal and mid-stem left main disease, the stents with drug-eluting stents is comparable with surgery. The results are comparable with surgery. However, the distal left main involving the bifurcation, bypasses may still be superior. And of course, isolated left main disease with LV dysfunction, a bypass is going to be superior than PCI. Let me show you one good example of left main osteal disease. A tight left main osteal disease. That's a very, very tight osteal left main disease. Patient also had a mid-LED lesion for which one stent was used. Osteal location of the left main being tackled with the balloon. The stent in the osteal left main. And an excellent result with the osteal left main lesion with the stent. However, if we find a patient something like this, who's got a distal left main disease, where a bifurcation of LED and circumflex, the patient obviously the balance would tilt in favor of a bypass surgery. What about acute myocardial infarction? If we say the stents, this is the indication of putting in stents or patients taking up for angioplasty. Whether it is a primary angioplasty whereby the patients come well in time and we take him up for an acute primary angioplasty, or whether the patients are sent us for a rescue angioplasty, that means that the thrombolysis has failed. In this setting, the culprit vessel angioplasty is the procedure of choice in majority of acute ST elevation myocardial infarction, and this is with adjunct thrombosuction in certain individuals, some GP2B3A inhibitors, abciximab, tirofiban, or eptifibatide, or in a situation where it demands patients who of cardiogenic shock, intra-aortic balloon pumps in association with acute myocardial infarction. We also have, this is one of the situations where we take the patients up for a primary angioplasty, and people with severe, turn out to be with severe triple vessel infarction, came with a lateral wall infarction, did a coronary angiogram, found that all three vessels, this is a significant disease in the LAD, the circumflex is occluded, even the right coronary is occluded 100%, clearly a surgical candidate. However, we don't have time at that point of time, only do a culprit vessel angioplasty, put in a wire through the culprit vessel, just open up with a plain balloon and leave it alone for the surgeons at a later time, because the surgeon is going to do much better job in such like patients. We have just to open up the culprit vessel at this particular point of time. Thank you very much.